Here is a structured, comprehensive summary of Chapter 1, Introduction from the provided textbook pages. Chapter 1, Introduction to Complete Dentures. 1. Introduction and Objectives of Complete Dentures. A complete denture, CD, is a removable dental prosthesis designed to replace the entire dentition and associated structures of the maxilla or mandible. It is indicated when all natural teeth are lost and other tooth-supported options are exhausted. Primary objectives of complete dentures. Compatibility with surrounding oral environment. Restoration of mastication. Harmony with functions of speech, respiration, and deglutition. Aesthetics. Preservation of remaining oral tissues. 2. Effects of aging on prosthodontic considerations. A. Bone and residual ridge resorption, RRR, bone changes, decrease in bone quantity and quality due to reduced osteoblast efficiency, lower estrogen production, and reduced calcium absorption. Residual ridge resorption, RRR, the diminishing quantity and quality of the residual ridge after tooth extraction. Resorption rate, most rapid during the first year post-extraction. 2. Text 3. Text mm in maxilla. 4. Text 5. Text mm in mandible. Subsequently decreases to 0.1, text 0.2, text mm annually. Mandibular resorption occurs 4 times faster than maxillary resorption. Women experience higher RRR than men. Atwood classification of RRR, Order 1, pre-extraction. Order 2, post-extraction. Order 3, high, well-rounded. Order 4, knife-edged. Order 5, low, well-rounded. Order 6, depressed B. Systemic, cognitive, and oral factors. Cognitive. Conditions like dementia impair masticatory efficiency, leading to poor nutrition and potential accelerated cognitive decline, e.g., linked to Alzheimer's disease. Oral factors, xerostomia, lack of self-cleansing by saliva, taste bud degeneration, coated tongue, and difficulty swallowing, chewing. Dentate status. Reduced masticatory ability pushes elderly patients towards softer, high-fat, carbohydrate diets, reducing vital nutrient intake, protein, iron, vitamins. Pharmacological factors. Common drugs, e.g., digoxin, phenytoin, text Ca, carat 2+, channel blockers, text H, endosco2 receptor antagonists, cause anorexia, xerostomia, nausea, and altered nutrient absorption. 3. Surfaces of complete dentures. Sir Wilfrid Fish, 1948, classified the complete denture into 3 distinct surfaces: impression, intaglio, surface, the portion that fits directly against the foundation tissues, determined by the impression. Responsible for retention, stability, and support. Occlusal surface, the surface containing artificial teeth that makes contact with the opposing arch. Directs forces of mastication to supporting tissues and contributes to stability. Polished, external, cameo, surface, the outer surface of the denture base, buccal, labial, palatal, lingual, excluding teeth. Shaped to accommodate lip, cheek, and tongue contours, contributes to retention and stability. 4. Component parts of complete dentures. Denture base, directs forces across the basal seat. Materials used, acrylic resin or metal. Denture flange, the portion extending vertically from the cervical region of teeth to the border. Labial flange, occupies labial vestibule, contains a V-shaped notch for the labial frenum. Buccal flange, occupies buccal vestibule, notched for buccal frenum. Lingual flange, occupies alveolar-lingual sulcus in mandible. Denture border, the junction between the polished surface and impression surface. Maintains the peripheral seal. Overextension causes ulcers, hyperplasia. Underextension compromises retention. Denture teeth, by material, acrylic or porcelain. By morphology, anatomic, GE 33 carat, circ, or modified anatomic, 0 carat, circ, text, 30 carat, circ. 5. Sequential steps in fabrication of complete dentures. Step. Clinical procedures. Laboratory procedures. 1. Diagnosis and treatment planning. 2. Making diagnostic casts. 3. Mouth preparation. 4. Primary impressions. 5. Primary cast and fabrication of custom trays. 6. 7. Secondary, final, impressions. 8. Master cast and fabrication of occlusal rims. 9. 10. Recording jaw relations. 11. Articulation. 12. Arrangement of artificial teeth. 13. Try-in. 14. Processing of denture. 15. Denture insertion and follow-up. Here is a structured, comprehensive summary of Chapter 2, Diagnosis and Treatment Planning based on the provided textbook pages. Chapter 2, Diagnosis and Treatment Planning. 1. Definition and Overview. Diagnosis, the determination of the nature of a disease. It involves patient evaluation, history taking, and clinical examination to understand the physical and psychological needs of each patient for a predictable outcome. 2. Patient evaluation, initial observations. Initial observation begins as the patient walks to the chair and during introductory conversation, gait, evaluates motor skills and potential systemic conditions. Stooped shoulders, spinal changes. Head tremor, Parkinson's disease, tranquilizers. Dragging one leg, stroke. Staggering, alcohol, medication, hyperventilation, brain or spinal cord damage. Age, refers to physiologic age. Younger patients who appear old may indicate disinterest. Older patients appearing young indicate a willingness to adapt. Facial expression, reflects mental attitude. Lack of expression may indicate loss of muscle tone, trigeminal neuralgia, plastic surgery, or CNS disorders. Complexion, guides tooth color selection. Pale, anemia, lack of nourishment. Ruddy, polycythemia, chronic alcoholism. Bronze, radiation therapy, Addison's disease. Bluish purple, vitamin deficiency, cyanosis. Lemon yellow, jaundice. Speech, hypernasality, paralysis of palatal musculature. Hoarseness, vocal cord paralysis, excessive smoking. Breathing pattern, heavy sighing, emotionally disturbed. Wheezing, asthma. Shortness of breath, lung disease, heart failure. Shallow, rapid, pulmonary fibrosis. Erratic, continuous hyperventilation. 3. Mental attitude, Dr. M. House classification, 1950, Class 1, philosophical, rational, compose, adapts quickly, highest probability of treatment acceptance. Best mental attitude, Class 2, exacting, methodical, precise, demands detailed explanations and extreme care. Requires additional time and patience from the dentist. Class 3, indifferent, lacks motivation and concern, apathetic, poor compliance. Needs patient education, questionable, unfavorable prognosis. Class 4, hysterical, emotionally unstable, excitable, highly apprehensive, unrealistically expectant. Often requires psychiatric counseling alongside dental treatment. 4. History taking. A. General and social information. Age, sex. Younger patients show better tissue healing. Women often prioritize appearance, affected by menopausal hormonal changes, while men tend to focus on comfort, function. Occupation. Executives may exhibit bruxism. Dusty environments require wear-resistant teeth. Public speakers, singers need extra retention and palatal contour care. Wind instrument players require precise anterior tooth placement. B. Personal habits and nutrition. Habits, pan chewing, smoking, chronic alcoholism, pencil, nail biting, causes instability, and bruxism, influences tooth selection. Nutrition. Evaluated via a 3 to 5 day food intake record to assess tissue tolerance under denture stress. C. Medical conditions and medications. Diabetes mellitus, high risk of candidiasis, delayed healing, and altered salivary flow. Joint disorders, RA, OA, TMJ, limits mouth opening, complicating impression taking and jaw relation records. Cardiovascular disease, short appointments, consult cardiologist if patient is on anticoagulants. Neurological, epilepsy, Bell's palsy, Parkinson's, affects record taking, seizure risks include aspiration or denture breakage. Medication side effects, antihypertensives, antidepressants, cause xerostomia, reduced retention, soreness. Diuretics, alter fluid balance, impacting retention. Psychotropic drugs, cause involuntary tongue or facial movements. D. Dental history. Chief complaint and expectations, recorded in the patient's own words. Unrealistic expectations must be addressed early through patient education. Past dental history, evaluates reason for tooth loss, sequence, duration of edentulism, predicts bone loss pattern, and past denture experience. Evaluation of current denture, assesses extension, jaw relations, occlusion, tooth wear, retention, stability, aesthetics, and hygiene. 5. Extraoral examination. A. Diagnostic aids. Pre-extraction records, diagnostic casts, radiographs, and photographs aid in tooth size, shape, position, and display determination. Diagnostic casts, mounted on an articulator using a face bow transfer to evaluate intra-arch distance, survey endocates, and plan pre-prosthetic surgery. B. Facial form and profile. Face form, Leon Williams classification, types, square, square tapering, tapering, ovoid. Guides the selection of artificial tooth form. Facial profile, Class 1, straight profile. Class 2, retrognathic, convex, profile. Class 3, prognathic, concave, profile. C. Lip examination. Lip health. Angular cheilitis, fissures indicate vitamin B deficiency, candidiasis, or loss of vertical dimension. Lip support. Upper anterior teeth placement must provide proper support to eliminate modulus wrinkling. Lip thickness. Thin lips are sensitive to tooth position changes. Thick lips tolerate variations better. Lip length. Short lip exposes more anterior teeth and labial flange. Long lip hides most of the tooth display and denture base. Here is a structured, comprehensive summary of the remainder of Chapter 2, Diagnosis and Treatment Planning based on the provided images. Chapter 2, Diagnosis and Treatment Planning, Part 2. 1. Intraoral examination, soft tissues and ridge anatomy. A. Muscular examination, House classification, Class 1, normal muscle function and tone, commonly seen with recent extractions. Class 2, normal muscle function with mildly decreased muscle tone. Class 3, decreased muscle tone and function, drooping commissures, exaggerated nasolabial fold, loss of vertical dimension. B. Mucosa and mucoperiosteum evaluation. Color. Redness indicates inflammation, ill-fitting dentures, infections, diabetes. White, brown, blue pigmented spots require biopsy if unexplained. Thickness. House classification, Class 1, normal uniform density, approx 1, text, mm, thick, firm cushion. Class 2, thin investing membrane, highly susceptible to pressure irritation. Class 3, excessively thick investing membrane with redundant tissue, requires tissue treatment or surgery. Condition. House classification, Class 1, healthy, Class 2, irritated, Class 3, pathological. 2. Residual alveolar ridge and interarch relations. A. Ridge features. Arch size, classified as small, medium, or large. Larger arches offer greater contact, support, and retention. Arch form, classified as square, tapering, or ovoid. Ridge contour, Atwood classification, order I, pre-extraction, to order VI, depressed. Ideal contour is high with a flat crest and nearly parallel sides. B. Interarch and positional relationships. Interarch distance, anterage distance, normal, ideal for tooth arrangement. Excessive, due to severe resorption, leads to increased leverage and poor stability, retention. Reduced, makes tooth setting difficult. Parallelism, non-parallel ridges lead to denture-based displacement under occlusal force. Positional relation, Class 1, normal, Class 2, retrognathic, Class 3, prognathic. Resorption makes maxilla move upward, inward and mandible downward, forward, laterally. 3. Palate, tongue, and surrounding oral anatomy. A. Hard and soft palate. Hard palate forms, U-shaped, good retention and stability, ideal. V-shaped, least retention. Flat, poor retention and stability. Soft palate classification, flexure angle to hard palate, Class 1, less than 10 carat, circ angle, wide posterior palatal seal area, GE5, text, mm, most favorable. Class 2, 45 carat, circ angle, 3, text, 5, text, mm, seal area. Class 3, 70 carat, circ angle, less than 3, text, mm, seal area, least favorable, associated with V-shaped palate. B. Gag reflex, lateral throat form, and tongue. Gag reflex, House, Class 1, normal, Class 2, hyposensitive, Class 3, hypersensitive. Neal's lateral throat form, Class 1, deep, Class 2, moderate, Class 3, shallow. Wright's tongue position, Class 1, lies flat, tip resting behind, below lower anterior ridge, best prognosis. Class 2, flattened, broadened, tip in normal position. Class 3, retracted, depressed into flow of mouth, ruins lingual seal. C. Saliva and tori. Saliva quantity, Class 1, normal, Class 2, excessive, Class 3, xerostomia. Consistency, ropey, thick saliva compromises intimate contact and causes retention loss. Tori, palatal, lingual, act as a fulcrum causing rocking, requires surgical removal if large. 4. Radiographic assessment and prosthodontic diagnostic index, PDI, a radiographic bone loss, Wickel and Swope method, measures original ridge height as 3 times distance from lower mandibular border to inferior margin of mental foramen. Class 1, mild, loss of frac 1, 3, vertical height. Class 2, moderate, loss of frac 1, 3, text, frac 2, 3, vertical height. Class 3, severe, loss of greater than frac 2, 3, vertical height. B. ACP Prosthodontic Diagnostic Index, PDI, for complete edentulation. Evaluated using 4 main criteria: mandibular bone height, maxillomandibular relationship, maxillary ridge morphology, and muscle attachments. PDI class. Complexity. Mandibular bone height. Key features. Class 1. Ideal, minimally compromised, GE21, text, mm. Ideal ridge relation, high horizontal, vertical resistance morphology, favorable attachments. Class 2. Moderately compromised 16, text, 20, text, mm. Continued anatomical degradation, muscle attachments slightly compromised stability. Class 3. Substantially compromised 11, text, 15, text, mm. Limited intra-arch space, angle class 1, 2, 3, ridge offers minimal movement resistance. Class 4. Severely compromised, LR10, text, mm, most debilitated, surgical reconstruction usually indicated prior to prosthetics.